Hello, and welcome to POMA Does, a podcast produced by the Pennsylvania Osteopathic Medical Association. We provide a voice for osteopathic medicine and share insights on issues important to osteopathic physicians, residents, and students, as well as those who embrace the osteopathic philosophy. POMA's mission is to promote the distinctive philosophy and practice of osteopathic medicine for our patients, our members, and the communities we serve. Thanks for tuning in.
Hello and welcome to the latest episode of the Pennsylvania Osteopathic Medical Association Does podcast series, sponsored by the Pennsylvania Osteopathic Medical Association. I am Dr. Kathleen McGonigal-Dio. I am from a graduate of LECOM, Lake Erie College of Osteopathic Medicine, and I'm board certified in family medicine with a CAQ in sports medicine. I'm also part of the POMA District 8 Regional Trustee and currently faculty and osteopathic principles and practice director at the LECOM at Seton Hill campus in Greensboro, Pennsylvania. Today we're going to explore the topic of engaging in conversations on weight management and weight loss. I'm privileged to be joined by Dr. Nicholas Pennings, DO, and Dr. Kim Bond, PharmD. I'd like to start by asking each of you to briefly share a little bit about yourself and your interest in today's topics, and then we'll go back to the topic for today.
Hi, I'm Dr. Nick Pennings. I'm a family physician. I'm board certified in family medicine. I'm also board certified in obesity medicine, and I have fellowship designation in family medicine and obesity medicine. I am a chair of family medicine at the Campbell University School of Osteopathic Medicine. I'm also a professor of family medicine, and I'm director of the health center there as well. Before going into academia, I was in private practice for 22 years in New York State, and that was a great experience for family medicine, but I really enjoy the academic aspect, especially as I am able to teach obesity medicine to the students. I've been able to integrate that into the curriculum. I also serve as the executive director of clinical education for the Obesity Medicine Association, and I help to coordinate a lot of the obesity education for continuing medical education, and I've actually developed online programs for medical students and residents to take through the Obesity Medicine Association. And lastly, I'm a graduate of the Philadelphia College of Osteopathic Medicine.
Alrighty, and thank you. It's great to have you here. And how about Dr. Bond?
Oh, hi. I'm a pharmacist at McCabe Drug Store in Reynoldsville, Pennsylvania. I'm the pharmacy manager there, and we are owned by Penn Highlands Healthcare. I went to school for pharmacy at the University of Pittsburgh, and I got my PharmD degree later on from Shenandoah University. My interest in the topic is that I help my patients understand their drug therapy and help get the most benefits that they can out of it, help them understand potential side effects, how to properly use the medications, just follow their therapy along and help them get the best benefit they can out of their medications. So we have an interest in all the new ones that people are asking a lot of questions on, and we're dispensing them a lot. And sometimes issues come up that I can help people with. So that's my interest in this area tonight.
Well, wonderful. So thank you again for joining us. So as we go back to the topic, as healthcare professionals, we know that weight can directly affect the health of patients and families, even our own family members. Studies have shown that many patients welcome advice from weight management and reducing health risks from their healthcare professionals. Some of them might find it difficult to start these conversations themselves. And sometimes these conversations can be perceived as challenging or uncomfortable even for providers. So my first question to open you up and talk about this subject is, how do you engage in these conversations with the patient about weight loss goals, weight loss options, weight management options in a both sensitive and effective way?
But I think one of the most important things is what you mentioned. Weight can impact health. And I think the discussion needs to focus on how weight may be impacting health, how it may be impacting blood pressure or lipids or glucose levels or other things like sleep apnea or osteoarthritis. If we stay focused on those components, I think that's less threatening to a patient and easier to have that discussion. One of the key components that we follow for interviewing and discussing obesity with patients is the 5 A's model. And the first of the 5 A's is ask. And we ask permission if it's okay to talk about this topic. And I think that's really important. One, it shows a level of empathy, letting the patient know that you recognize that this may be a difficult conversation. I also think that it is helpful in that you get a sense of, is that person ready to talk about it? And if they're ready to talk about it, then you can really have a conversation much more easily only if they give you permission to talk about it. And if they're not ready to talk about it, one of the things I always say is I like to leave the door open. I would say to the patient, I think this is a very important issue for your health. And when you're ready to talk about it, I'd be happy to talk to you about it and help you in any way that I can.
On that same area, then once you kind of assess the patient, where do you go from there after you open the door, I guess?
So then talking about what are the different options for treating weight, and there's lots of different options, and there's lifestyle components and there's medications and there's surgeries. In the Obesity Medicine Association, we talk about the 4 pillars, which are nutrition, physical activity, behavioral modification, and medical therapies, which would be medications or bariatric procedures. And so talking about nutrition, looking to see what are the unhealthy aspects of their diet. One of the things I'll ask patients, what is the least healthy aspect of your diet? Or what aspect of your diet might be contributing to your diabetes the most? Or what might be contributing to your blood pressure the most? And then we might center on those things. There's lots of different dietary interventions, and I think it's important to have some specific recommendations. But if you look at dietary recommendations, none of them include sugar-sweetened beverages, high sugar content foods, or ultra-processed foods, right? So just eliminating those, or fast foods, or just eliminating those things can be a big step to moving forward. Then looking at physical activity, developing a physical activity plan, an exercise plan. We use that FIT model, frequency, intensity, type, and enjoyment. So it's a fun acronym that can be used to kind of set up a plan. And we like to set very specific plans. And then behavioral modification. We're really looking at the why you eat. Why you eat is very often a bigger factor than what you eat. We eat for emotional reasons. We're happy. We eat when we're sad. We celebrate with food. We have a lot of social aspects around food. Those are big factors that have nothing to do with hunger. And so that's a big part, as well as talking about sleep. Sleep is an important part. We target 7 to 9 hours of restorative sleep as the goal. Many people get less than that. And when you get less than that, your hunger signals go up, your fullness signals go down, and you're going to eat more. And then medications. There's a host of medications to talk about. I was curious with Dr. Braun, if you touch upon lifestyle issues with patients that are getting their prescriptions filled, is that something that you discuss with them?
Yes, I touch on that. Also talk about some changes they can make to what kind of food choices they make, reducing the number of calories they're eating, empty calories, sugary foods, fried foods, ultra-processed foods, and just mentioning that they should, if they're able to, increase their physical activity, and some ideas for exercise they can do with their various limitations, and maybe sometimes even mention they might want to speak to a nutritionist to help them. It comes up a lot with my diabetes patients, but also patients who are interested in weight loss medications.
And I think that's an important point. You mentioned referring to a nutritionist. I think tapping into your resources in your community is really important when you're treating, because as a primary care provider that is trying to manage all these different health conditions in one visit, and with the amount of training that we get in nutrition and physical activity and behavioral modification, it's important to be able to tap into your community resources. So working with a dietitian or a nutritionist, or working with an exercise physiologist or physical therapist or an experienced trainer, or working with behavioral therapist to be able to complement those. And then of course working with your pharmacist with giving advice with the medications, I think is really important.
Yeah, I think that they need a well-rounded approach to weight loss, because the medicines aren't just a magic bullet. So we have to also encourage healthy eating and being active.
So when you come across that whole discussion with the medications, obviously, because that's our hot topic today in general in society, do patients, say, Dr. Braun, do they just approach you also before they've seen the doctor and kind of ask about the medicines?
I'd say most of my conversations are after a prescription's been prescribed already, but I do have some people that are interested and they want to know what the options are and if their insurance might cover the medication or what kind of problems they might run into, so I can advise them before they see the practitioner also.
Are there some pros and cons to the different weight loss medication lines?
Yeah, well, there's lots of different options out there. And so phentermine is a medication that has been around for a very long time, approved in 1959. It's only approved by the FDA for 12 weeks, and the regulations around that vary by state. In North Carolina, I don't have a limitation on how long I could prescribe it for. Dr. Braun, in Pennsylvania, are there limitations to how long you can prescribe phentermine?
We just go by the FDA recommendation for up to 12 weeks. I do see some providers using it longer or taking a break from it after 12 weeks and then resuming it. In Pennsylvania, they could resume another 12 weeks if they chose to do that.
The challenge with that is that obesity is a chronic condition and it needs a long-term treatment. So 12 weeks just doesn't cut it. It's like treating blood pressure for 12 weeks and expecting a long-term result. It's not going to happen.
I agree too. And I have some concerns with the use of that medication too. Some things that might occur with blood pressure, cardiovascular wise, that would be concerning.
I've used it in some patients. I've actually used it even for years in some patients. And what we find is that when they lose weight, their blood pressure tends to go down. So it certainly is something you monitor and certainly something you watch, but it is something that I've used longer than that without, seeing any complication. It actually seemed quite effective, and it is much more cost effective. But there's other medications that have been out for a while, the Saxenda, which is liraglutide, and Qsymia, which is a phentermine topiramate combination, and Contrave, which is a bupropion naltrexone combination. And those have been around for a long time, but their weight loss results are not nearly as robust as what we're seeing with the semaglutide and tirzepatide that we've seen. But I still use some of those medications at times because it's like the antidepressants. If one works well in one person, it may not work in another person. And we see variability in response to those medications.
Right. Some people can't tolerate the ones that are more effective either.
Right. Some of the side effects that we see when you talk to patients about the side effects on the GLP-1 and the GLP-1 GIP receptor agonist, the semaglutide, tirzepatide. What kind of advice do you typically give for patients that are taking those medications?
Well, first I talk to them about some contraindications to use. If they have a history of thyroid cancer in themselves or their close family, I tell them to talk to their doctor first. We'll talk about the risks of pancreatitis, gallstones, acute kidney dysfunction if they were to get dehydrated. So I talk to them about the GI side effects that can occur that tend to happen when you first start the medication or when you titrate the dose upwards. So I tell them that we don't want them to get dehydrated even if they feel sick. Make sure they continue drinking enough. And if the medication does make them feel nauseous, they want to eat smaller, more frequent meals and try not to overeat. Don't eat real close to bedtime. Just things like that can help with the nauseousness.
I have my 3 F's that I use for recommending. Don't eat too fast, because when you eat fast, then it tends to make you nauseous. Don't eat until you're too full. Eat until you're just not hungry anymore rather than waiting until you're full. And very often patients feel full much quicker with these medications. That's one of the ways that they work. And the third is not to eat too much fat. So when they're eating fried foods or foods that have a high fat content, that tends to cause more nausea. They do work well, but I think it's important to understand, why do we even use a medication for the treatment of obesity? What is the role of that? And I think it's important to understand pathophysiology that is happening here. When we skip a meal, when we don't eat, we feel hungry. That's not a good feeling. We get a name for it. We call it hangry at times when we don't eat. But that's physiology. When we don't eat, our ghrelin levels go up, which is a hunger hormone. Our leptin, GLP-1, CCK, PYY are all satiety hormones, fullness hormones. They go down. And so when we calorie restrict, when we're losing weight, we are in a negative energy balance. Those hunger signals go up, those fullness signals go down. And it's very hard to sustain that. In fact, the more weight you lose, the more intense that feeling becomes. And so the role of anti-obesity medications is to treat that symptom, to treat that hunger that occurs with those medications, that occurs during periods of weight loss, that occurs when you're calorie restricting, and that makes it a lot easier. That it's something that we see in patients. I think one of the most interesting things I hear from my patients is that they say that the food chatter in their head goes away when they're taking the GLP-1 related agents, that they're not thinking about food all the time. I find that to be very interesting, how common that occurs Dr. Braun, is that something you hear from patients as well?
Oh, yes. It seems to have a big impact on people when they start these medications. And it's just a profound effect. They look like completely different people once they've had about 3 to 6 months on these medications, and they're doing well. They seem very happy with it mostly. So I do think it's been a dramatic impact on this category of medications, these GIP/GLP-1 dual agonists and the single agonists have a big place in therapy now.
Great. So then how about when you're deciding and you started a patient on these medications or you're counseling them on starting it, do you ever kind of also regroup the patient if they notice that maybe they're also eating because it's more behavioral and then it's not just the food chatter, but they suddenly realize when they're stressed, they're not even hungry, but they're eating. How do you readapt to adjust for individualized treatment for your patient?
One of the things that's important to remember is that they need to eat enough. And that's one of the kind of the paradigm shifts that I've seen with patients that, as an obesity medicine specialist, where I've been trying to get patients to eat less for a long time. And now suddenly it's a shift and I've got to make sure that they're eating enough, because we do find that people, their appetite is so suppressed that they are not eating enough, so that they are skipping meals and they're not getting enough protein in their diet. And then one of the things that you can have as a consequence to that is loss of muscle mass. And we hear a lot about sarcopenia and about loss of muscle mass associated with these medications that is related to inadequate protein intake and inadequate physical activity. That if you just take a medication and you're not careful about what you're eating, then you're going to lose muscle mass. And if you're not doing some resistance type strength-based exercise, you're going to lose muscle mass. That's not the mass you want to lose. You want to lose the fat mass, not the muscle mass. So you typically want to get 80 to 100 grams of protein in your diet. People to eat regularly throughout the day, several times during the day, to be able to get that, because it's hard to digest more than 30 grams of protein in a meal. So if you're targeting 80 to 100 grams of protein in a day, you're going to need to split that up into different segments. So that is an important part. And one of the things that I take is lessons from the bariatric surgeons, because they've had to deal with this all along. And part of the mantra with bariatric surgery with respect to nutrition is prioritize your protein first, then your vegetables, and then anything else after that. Usually you're full by that time. But if you're prioritizing protein and vegetables in your diet, you're going to get the protein you need. You're going to get the other nutrients your body needs, because it's not just calories you need. You need vitamins, you need minerals, you need fiber, you need protein. So you need to make sure that you're getting those components in your diet. And I think the bariatric surgeons have done a good job with that. And that same applies to the GLP-1 medications. It's a shift in mindset. We often think about living to eat, and now you're eating to live. It's a different way of thinking about food. So making sure that you're doing that, and then incorporating some strength-based resistance type exercise at least 2 days a week as part of your exercise routine. And that can go a long ways to help you from losing any kind of muscle mass.
Awesome. As far as just following patients along, is there any particular diagnostic or lab tests that are a good idea to keep in mind for the patients?
I think it's very important to see patients regularly while they're on the medications. I initially see my patients every month. Then as they get more established, I do it every 2 months to 3 months. But I don't think with these medications it's appropriate to start them and then just not see them for 3 months. So I think close follow-up is really important. You want to be measuring vital signs. You want to be measuring affect and some of the mental health aspects of it. You want to be screening for depression or any of those types of side effects that are sometimes associated with all of the medications. They can change, you change your relationship with food, and food is a big part of our emotional being. So that's an important thing to be looking at. I look at blood pressure, listen to heart and lungs, and really monitoring for what kind of side effects they have. And I also talk to them to make sure that they're eating enough. So that is an important part of monitoring. As far as labs go, I think what's important when patients are on these medications, it's important to be aware of what other medications they're on, particularly with blood pressure and diabetes medications. Dr. Braun, do you talk to them about their dosing of diabetes medications and blood pressure medications while they're taking GLP-1 agonists?
Yes, you might see that they need less and less of those other medications. Some of them might need to be reduced or even eliminated as they begin their weight loss journey. It's just needing them to check in with their provider regularly and make those adjustments so they don't have side effects.
I think that's really important that they be monitoring their blood pressure at home, that they be monitoring their blood sugars, that they be watching for any kind of adverse reactions, and then not to hesitate to take them off of medications if their blood pressure drops or their sugar drops. It's a very happy thing in medicine to be able to stop a long-term medication because they're healthier.
Right. We don't see that enough.
We don't.
It's always probably a great discussion to have that now you can come off of stuff.
It's a very happy visit when we can do that.
What about when they are on this whole momentum train, that they're doing great and things are going well and some of their other medicines are being titrated down? How do you kind of keep the patient motivated or, keep that momentum train going for them?
When they're losing weight, it's easy. They're often self-motivated because they're seeing the changes on the scale. They're getting comments about it. Actually, I think the hardest part of weight management is maintenance. Maintenance, I describe, it's like having a job where everything you do right is taken for granted and everything you do wrong is harshly criticized. And I think that's what people do when they get to weight maintenance, that they get on the scale and if it's the same, it's like, well, it should be the same. And if it goes up, well, then they're upset and it can be very frustrating. So I think it's important to recognize that when you get to a goal weight, that you count the number of days you're in that kind of goal weight range, usually like a 5-pound range. I recommend people count the number of days, and that's a way you can see continued progress, because the more days you spend in that target range, the more likely you are to have long-term success.
How about Dr. Bond? Do you also have experience in the process of maintenance?
I'm just trying to encourage people to stay on the same path if they're doing well and they're feeling better and they're like their other medications, they might be reducing them or not needing so many of them. I think all of that gives them a good feeling. I have more energy. Just try to encourage them to stay on the same path and give them reminders to get their prescription refilled on time. And I was going to ask Dr. Pennings if he sees very many of these people, he starts to de-escalate the dose and have them come off and then just monitor their weight periodically. Do you see very many people that can come off of the GLP-1 agonist once they meet their goal weight?
So I think the studies are pretty clear. When you meet your goal weight, if you just stop the medication, you will regain weight. And that's because the physiologic drivers of weight gain are still operative. When you lose weight, when you get down to your goal weight, there was an interesting study in the New England Journal by Sumithran in 2011 that looked at people that had lost 14% of their body weight over 10 weeks and then maintained it for a year. And they looked at those hunger signals and they looked at those fullness signals, and they looked at them before they started the diet, after the 14 weeks, which at the end of the 14 weeks when they hit their goal weight, their hunger levels were higher, their fullness signals were lower, and then looked at it again a year later. And a year later, ghrelin, or the hunger hormone, was higher, the fullness hormones were lower, and the desire to eat was actually higher at the end of a year than it was right after the 14 weeks. And so to me, that is kind of a clear indication that this is a chronic disease and it needs a chronic treatment. So no different than, if you treat somebody for hypertension and you get their blood pressure down, you stop the blood pressure medication, their blood pressure goes up. You get somebody's diabetes under control, you stop the medication, their blood sugar goes up again. And if you stop the medication that's regulating their appetite, their hunger is going to go up and they're going to gain weight again. And so I look at that as a long-term treatment. Some people that really implement lifestyle changes that are sustainable and they don't have a high level of hunger after they lose weight. And for those patients, I'll de-escalate the dose and sometimes even be able to take them off of it. But I never create the expectations that we're going to stop the medication at some point when we start it. I think we have to go into it with a mindset that this is a long-term treatment. And if we can, we will. And I always look for that opportunity because I always feel the least medicine is the best medicine. But by the same token, I don't want to have an expectation that just because you lost the weight, now you're done. That's the mistake that people have made that has caused the yo-yoing of weight for so many years.
Thank you.
Excellent points. Thank you for bringing them up. And it's good to have that perspective when you start the medicines on patients too. I think you both mentioned this many times, just thinking of the whole idea of everything that's going on with the patient in their life and not just focusing on just the number on the scale, which is really critical too. So do you have any other resources resources? So if a patient or family member has weight issues, are there any tips or resources that can help our listeners to talk with them about their weight in a sensitive and effective way?
I think if you're particularly concerned about the discussion and the impact of obesity, stigma, and bias in society, the Obesity Action Coalition is a great resource as an advocacy resource for patients with obesity. And I think that's something to look at. There's lots of resources out for dietary support, for physical activity, for behavioral modification, for stress management, for sleep. I like the CBTI Code app for sleep. That is an app that is put out by the Department of Defense and Stanford University. The free app, and it gives all these tips for helping to improve sleep. But there's a lot of different sites and resources that you can use. I think that's important to get familiar with some of the better ones. Actually, one of the questions I wanted to ask Dr. Braun, and this is a common question that we all get, is dealing with insurance and covering these medications. And if he had any further insights for providers on how to get these medications covered for patients.
That's one of the biggest obstacles for my patients at the drugstore is having their medication covered. When they think once the medication is sent into the pharmacy, that, they'll be able to come in and pick it up right away. But usually there's a delay because the insurance companies usually require prior authorization process. So we send the information back to the provider and ask them to contact the insurance and try to get authorization. I think as long as the medication is indicated and the patient's BMI is in the range that's indicated or they have comorbidities, they tend to be getting the approvals pretty regularly now. I'm seeing faster coverage, I think, on some of these medications. That is still an obstacle.
What do you see are some of the key things that healthcare providers should be documenting in order to get it covered?
I think just documenting the BMI and the other comorbid factors that might be problematic for someone, that obesity can play a role in so many other disease states. I think those are all things that would be documented and would help get the medication covered. But another thing that we're seeing issues with is availability too. So sometimes even once the medication is approved, we're having trouble sourcing that medication because it's not available or it's on a manufacturer back order. So we have a couple different obstacles for patients right now.
So do you recommend providers let the patients know they should call the pharmacy early if they're going to be due for a refill, not your usual?
Right. We let them know which ones, and sometimes it's only certain strengths. So we let them know to call us ahead of time that we're having a struggle sometimes getting the medication in stock in a timely manner. So people are calling in ahead, and that's a big help.
And do you know if some of the drug companies themselves have some sort of assistance program for patients if they wanted to apply?
They do. You can look for savings cards on the manufacturer's websites. Some of them have savings cards, some of them don't. So that can help reduce the copay if the person doesn't have federal or state-funded insurance. Then you can add a savings card onto some of these medications.
And Eli Lilly just initiated a program where you can get the medication in vials, the 2.5 and 5 milligram dose of tirzepatide in a vial that you can draw up from Lilly Direct.
Oh, I didn't know about that.
Yes, and they're offering it at a lower price. I think it's about $300 for the 2.5 and about $500 for the 5 milligram dose.
Wondering too, as you mentioned that some of our listeners may not realize, but are all these drugs refrigerated or is there special handling of them?
The GLP-1 agonist and the dual agonist are refrigerated medications. They're injectable. The oral medications that Dr. Pennings discussed, those are all just room temperature storage.
So I think another question to ask Dr. Braun is, what should patients do if they miss a dose, and how many doses can they miss before they have to consider going through a titration process again?
Well, I was just looking with tirzepatide, and if you take your forgotten dose within 4 days, you can just start your schedule up back again. You want there to be at least 3 days between doses. You could go back to your regular day to get back on track. I'm not sure how long, if you were off of it, you should start low and titrate again exactly. But we've seen that happen because of the availability issues. We've had people have to go back to the beginning and start over again. Otherwise, it would cause too many GI side effects to go right back to the dose they were on before.
And I usually will continue the same dose if it's been 2 weeks or less. If we're getting closer to 3 weeks, then actually what I ask the patient is, how many GI side effects did you have when you started? Because Some people have nothing and some people have severe, more significant side effects. We titrate back up again. But if they didn't have any side effects, I have them try it back at the same dose if it's been 3 weeks. Beyond 3 weeks, I would always titrate back up.
So for both of you, what kind of counseling or what do you do when you're titrating patients off if they are having side effects or titrating it up into having side effects? What's advice or what do you look at with those patients?
If they're having side effects, I'd recommend that they talk to their provider. If they've tried things that we've discussed in the past, some helpful hints and tips, and they're just not working, they could try another drug even in the same category. Sometimes I've seen patients who could tolerate one over another and will wind up having success. So I do talk to them about other options. If they're having side effects, I don't think we want them to be having terrible GI side effects all the time. So we try to get them to switch and give something else a try.
And what I'll usually do is I'll slow the titration process. So instead of increasing every 4 weeks, I might increase at 8 or even 12 weeks. Or sometimes I leave patients at a lower dose, particularly for the tirzepatide, that they have good efficacy even at the 5 milligram dose. So if patients can't tolerate the titration to 15, sometimes you can stay at a lower dose. With the semaglutide, insurance companies are not always happy about covering it when they're on if they're on less than 1.7 milligrams a day. So that can be a little bit dicey, but I find that the side effects tend to wane the longer you're on the drug. And usually the greatest side effects I find are at the initial doses, that even though you're going from, like in semaglutide, 1 milligram all the way up to 1.7, I don't usually see a lot of side effects with that dosage change as much as I see somebody getting side effects with starting it or going from the 0.25 to 0.5. I don't know if you find the same, Dr. Braun.
I do. I agree. It just seems like when you first start it, that's when the most of the side effects are going to appear. I don't have too many patients tell me they have complaints when they do have those small incremental changes. And I do have some people that don't make it to the full target dose also, but still seem to be losing weight and doing well with the medication. I agree with the tirzepatide 5 milligrams. Sometimes the patient never goes up above that. Same thing with the semaglutide. I have some people who are on the 1.7 milligram. They never made it to the 2.4, but they're still happy with the progress that they made.
Well, wonderful. So it sounds like in general from our discussion that by, speaking with your patients in a respectful and sensitive manner and collaborating with them as a whole team approach with the pharmacy, the other caretaker, the other individuals like nutrition or other behavioral health that can be involved, as well as the provider, that we can be able to help them reach and maintain a healthier weight in the process. So we've covered a lot of ground today. Any closing thoughts from either of you for our listeners?
I think you make a great point in summarizing that this is a difficult discussion to have because there's a lot of emotion around it, because society in general is very judgmental about weight, and that makes it a very sensitive topic. There's a lot of history of frustration about losing weight and gaining it back, or trying to lose weight and not being successful. And I think that packs a lot of emotion behind it, and it makes it for a hard discussion, and you need to make sure patients are ready to have that discussion. It also takes a lot of energy, time, and focus and effort to be able to lose weight. If you don't have that time, energy, and effort, if you're going through stressful periods of life, it may not be a good time for you. And so you have to work with the patient, make sure that they're ready to commit and put the effort into it that it's going to take in order to succeed. And if you do, then there's lots of tools. Learn about those tools and utilize those tools to help people succeed.
And Dr. Vaughn, do you have any other thoughts or recommendations?
I just think we should encourage people to try to, as I said, maybe see a nutritionist if they need help, or join a support group that can help. I think those type of things will help get them to the goals that they need. I just encourage them to talk to their provider and stay in contact if they're having any problems with the medications.
Well, I would like to thank each one of you for your time and all the expertise that you brought into this discussion. It really benefits everyone listening. For our listeners, we hope this helps you engage in a conversation on weight management and weight loss, or at least start the conversation. If you have any other feedback or episode ideas, please email POMA, POMA at POMA.org, and be sure to subscribe to POMA Does, a podcast series on your favorite podcast platform or on POMA's YouTube channel. And we'll see you next time. Stay healthy. Thank you all.
Thank you.
Thank you.
Thank you for joining us for this edition of POMA Does. Be sure to subscribe to POMA Does wherever you listen to your podcasts, and tell your friends and colleagues to tune in. Learn more about osteopathic medicine and POMA on our webpage, www.poma.org, and join the conversation on social media. We're on Facebook, Instagram, LinkedIn, Twitter, and YouTube. Or email us at poma@poma.org. We'd love to hear from you. Join us next time for another edition of POMA Does.